Oh, hey, Chris.
Hey Chuck, how are you?
I'm great. I had so much fun with our Journal of Hand Surgery first part of our journal club that I'm looking forward to part two today.
You just couldn't wait. You couldn't leave any time between the first and the second installment. You just decided that you're going to jump right back on a Zoom and do another one on a Sunday morning.
Absolutely. I mean, you get it going. You got your flow. You got the whole setup. Let's get it done.
So for those of you that weren't glued to your podcast for the last episode, we're starting to do a new initiative, a new partnership with the Journal of Hand Surgery. Greg Merrill took over as editor in chief, starting I believe at the end of 2025 or early 2026, and has asked that our podcast help highlight some of the articles that have been recently released in JHS. So we'll continue to do that. Just wanted to mention that planning in preparation for the 2026 WashU Nerve Course is in full swing. We'd love it if you guys were interested in coming to St. Louis, May 29th to 30th, so the weekend after Memorial Day. Here in St. Louis, we're going to have faculty from plastic surgery and orthopedics here at WashU. The faculty are going to include people that are currently at WashU and also our extended nerve families, so our alumni who are practicing throughout the US and Canada. So it's going to be great. We have a day and a half of lectures and half a day in the cadaver lab. Really well received last time. A lot of excitement and enthusiasm. So please come to St. Louis. And there is a bonus session on Sunday morning, which is optional, but RSVP required, where you can spend a morning with Dr. McKinnon. She has a bunch of lectures lined up where you can bring things to ask her, and people have really liked that in the past. So again, it's optional, but again, it was a big hit last time. So please go. We'll leave a link in the show notes to register. So we still have some spots left. We'd love it if you came to St. Louis. A lot of opportunity to to learn and for us to learn from you as well.
I love it. I love it. And um, how many spots do you have? Obviously, it has to be limited because of the lab, and I'm sure it's going to fill up. Do you know how many spots are left?
So we still have probably about 20 spots left for the lab. The lab will, again, because we want to provide a good experience, will be a big part of it. But we do want to make sure that everybody has an opportunity to do some dissections, and engage with the faculty. So it is limited with that with regards to the lab.
Perfect. Well, I love that you're doing this and love that it's been so successful. And I have no doubt that this will be filled up soon. So if you're listening, hopefully it's not too late.
Yeah, I wanted to shout out our sponsors as well. Platinum sponsor is Checkpoint Surgical, Orthocell, and Axygen are also sponsoring, as well as BioCircuit. So I hope that you guys will just book your flights to St. Louis. It's going to be fun. It's going to be May. It's not going to be too hot. It's going to be gorgeous. It'll be so fun.
I love it. I love the optimism. While on the topic of thanking our sponsors, the Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/the upper hand.
All right. Should we? I mean, we talked about presenting a case, but maybe we should just jump into these articles. They're good ones, and I think there's plenty to talk about.
Yeah, so the first article I wanted to bring up is called Biomechanical Comparison of Suture Caliber and Number of Passes in Epitendinous Repair. First author is David Cardenas, and the senior author is Douglas Sammer. So this is from the group down at UT Southwestern in Dallas, plastic surgery group. So this was interesting. Very simple and straightforward research question. Before we jump into the details, what's your current preference for core suture? Both what type of suture you might use, the configuration, as well as epitendinous suture in, let's say, a zone two flexor tendon repair, not a revasc or replantation.
Yeah, first I'd like to say I still consider Dr. Sammer a part of the extended WashU family. He
That's
was
right.
here for a number of years
That's
before
right.
heading south. And Doug has always been good about doing meaningful research work, and this certainly is no exception to that. My preference in adults, and I do think it's important to emphasize adults. I like a six-strand core suture. Our partner, Dr. Boyer, always likes to give us grief when we don't do the eight-strand, but usually I'm a six-strand kind of guy, which is I like the modified Tajima, which sort of adds a horizontal mattress to a standard for a core for strands, and I like a locked. Epitendinous suture with 6-O-proline. It's interesting. When I was in training, there was a lot of talk about the configuration of the epitendinous suture and the silver skull. There was all kind of different techniques, but I tend to keep it pretty simple. And this is a really a nice look at how we should think about that epitendinous suture and kind of its critical nature and how much strength you can gain.
Absolutely. So just a follow-up question for you. So for your six strand, are you using a looped suture for that? And are you counting that as two strands?
I am and I am.
Okay, okay. Um,
um, what do you do?
I will typically use, if I can tolerate that tapered needle on the looped suture, I will do something very similar to what you described. If we're doing multiple tendons, I usually just use an ethibond and just do at least four strands. If you're doing multiple ones, and then I approach the epitendinous in a similar way. The question I always get when we're doing epitendinous is, do you have to be circumferential? So do you typically strive for circumferential? I mean, because if you're going circumferential, you're far exceeding 6 or 8 passes.
Right. I do try to be circumferential and it is a little trickier. And I'll admit that on the backside, I may have slightly fewer, maybe it's two or three on the backside and five or six around the sides and in the front. I do try to be circumferential. Although there's benefit, I think, with whatever you do, you just get more strength.
Yeah, I think what you're trying to do here is your core suture obviously is doing the vast majority of the work, but this hopefully you don't need it, but the epitendinous will help minimize some of that gapping. And, Dr. Boyer's work has demonstrated how important it is to avoid said gapping.
Yeah, yeah, and I think it's interesting. I wonder if there were to be a survey, which I will not be doing, if there were to be a survey of Hand Society members, how many routinely, and there would have to be an honesty test in there, how many routinely do an epitendinous component to their core suture? And I wonder what that number is. I think it's not the same as it was years ago when there was a lot of talk about flexor tendons and a lot of rigor to the technique and the epitendinous component. My guess is it's less than 50% of surgeries or tendons have an epitendinous suture, but that's sort of a wild guess.
That's interesting because I would have never even thought the question. I thought everybody did epitendinous sutures.
Well, I hope I'm wrong. And if you're
Yeah.
listening and I am wrong, tell me.
I thought that was kind of like what everybody does. But it is interesting how, a couple of influential people retiring, uh, we don't talk about flexor tendons that much anymore, with Dr. Gelberman not having the huge flexor tendon grant, with Peter Amadio not having a huge flexor tendon grant. We just don't talk about it as much anymore. And I don't think it's because we figured it out. I think it's because people's interests have changed.
Yeah, and there are some new technologies being applied in this space, which I think is highly relevant. Some of them are impressive. And yeah, and then there's also talk about other techniques that simplify the process. And so, do you or do you not repair FDS in a zone two, especially if, in certain situations? And I think that's a really critical question. Do you repair both strands or one strand of FDS if you decide to do a repair? Can you vent pulleys? Can you release a single pulley? Those are all newer concepts back compared to the heyday of flexor tendons.
Yeah, I think the biologic augmentation is going to be really interesting. I think that's where you're going to see a lot more innovation. I know there's some groups that have been working on that quite a bit. So before we dive into this article, what type of suture do you use for your epitendinous?
Oh, I thought we already were diving in this protocol.
We haven't gotten into the actual methods yet. This is a segue into the methods.
Awesome. I use a 6-O proline. What about you?
Are you going to use a 5-O Perlene now?
I would think about using a 5-O proline. It always is, trying to avoid the bulk, which can be a drag on, tendon gliding. But
Was
I
that a
would
flexor?
absolutely.
Was that a flexor tendon pun? A drag? That
Yeah. Yeah, it was. It
I love
was.
that. I love that. You don't want the
Drag on the
situation to get too.
coefficient.
You don't want it to get sticky situation here. So, I will ask if I have a 5-O proline based on this study because I actually don't know if we have 5-O proline readily available. At least where I work.
Can you, I lost you for a second. Can you say,
I'll just start
I'll
again.
ask, oh yeah, just say
Yeah. So
about the
based on
5-O.
this, based on the study, I'm actually going to see if we have 5-O-proline available pretty easily at the surgery center where I do the majority of my work, and I'm sure it's at the main campus. But I typically would strive for about the fellows always ask, do you need to go circumferential? And I'll, for pragmatic sakes, I typically go 270 degrees as opposed to 360, and I will typically do a simple and lock it every now and then. And similar to what's described here, taking about a 2 millimeter bite back from the cut tendon edge. In the past, I've kind of toyed with doing an epitendinous back wall first kind of thing. It sounds cute. Doesn't really help me, to be honest with you. I think your core suture is probably more important. Um, and then the biggest thing I tell the fellows and residents is that, everybody breaks this stitch when you're tying it. Just don't break the stitch. Remind yourself it's 6-O proline. And maybe it's better with 5-O proline. But I was doing an epitendinous, the other week, and I broke the stitch, even though I told the resident fellow, I'm like, hey, like I'm gonna try my best not to actually break this stitch as I'm tying it down. But it's also like it's like the last thing in the case, and you just want to get out of there. So then you just
all,
throw another pass and then tie it together, and it's fine. But
all true, all true. So briefly, this was a cadaveric biomechanical study in the lab. There were three groups of 10 cadaver flexor tendons each, with either 5-O or 6-O proline and either 6 or 8 passes, with a standardized 3 millimeter purchase distance and 2 millimeter depth. And those tendons underwent mechanical testing for ultimate tensile strength, 2 millimeter gap resistance, and stiffness. And so, from my perspective, and I would never call myself the most sophisticated biomechanical testing guru, I think this is well done.
yeah, it's straightforward. It's a classic tendon study. You pull on it to see if when it gaps and when it breaks. And when it failed, it was the stitch, except for one case, the stitch pulling out of the tendon. So that's and then there were no knot failures, so it wasn't the technique, so to say, for the repair that was performed. Um, but yeah, this is interesting. It's a straightforward question. I think it's a not the most complicated study design, but it answers the question. A very simple, but clinically meaningful question.
Yeah, and this is one of the points that Dr. Gelberman would emphasize to me is that, a quote unquote straightforward study that answers an important question is invaluable. We fall down in our research when we try to do things that are more complicated, or we create our own set of difficulties with unanswerable questions because they're too complex. So this is great. This is really a great way to think about a straightforward issue and answering the question. And that is exactly what they've done.
Yeah, and I mean, the fact that both of us are saying, "Hey, yeah, probably use a 5-O next time. Probably do 8 passes next time." Like that. I mean, well done. Kudos to the study team for that.
Absolutely. All right, let's move on.
Let's
Are we
get
going
to the
sports or nerve?
Let's go sports to the most technically complex study that we've reviewed in this series of 6 that Nash and Macerena gave to us. So this is weight-bearing CT analysis of scapholunate ligament injury. First author is Brody Ritchie, and senior author is Neil White. This is work that comes out of Calgary, from the University of Calgary.
Yes. Um, this is a
I'm going to let you
interesting.
unpack this one.
Well, thank you for that opportunity. This is an imaging study, and it uses 10 healthy controls versus 10 patients with scapholunate interosseous ligament injuries. And so the imaging positions are essentially neutral with no weight bearing on a push up bar, and weight bearing in forced wrist extension. And what they do is with the CT scan, they then measure 6 variables: the scapholunate interval, the scapholunate angle, the capitate radius index, the radiolunate angle, the radioscaphoid angle, and the dorsal scaphoid translation. So all of those are familiar to all of us, probably except for the capitate radius index, which is a little different. Maybe I'll stop there and see what else you want to add about the methodology.
Yeah, so I mean, I think that for those of you that aren't familiar with a push-up bar, I mean, this is the wrist is being loaded axially, but in neutral rotation or neutral, no flexion or extension. as opposed to that forced extension, which would be like a traditional push-up position. I think the relevance of that is, patients want to get back to doing push-ups, and we usually tell them do it on a push-up bar or do it on dumbbells instead. It's probably better for your wrist. So I think those are two distinct things that may not come across, at first glance.
Yeah, was that a dig at me about the push-up bar, not knowing what a push-up bar was? That's how I heard it.
I'm just trying to make it accessible to everybody. There might be some people that don't have never seen a push-up bar because they're so good at doing it on their wrists.
Yeah, yeah, perfect, perfect. The images in this manuscript are interesting and helpful. I will say to those of you who are intrigued by this manuscript, there are some good descriptions of all those things we just stated. And so, what did they find? Well, first of all, weight bearing definitely alters carpal mechanics. There's a reduced capitate to radius index. There's a reduction of the SL angle under load. There's elimination of the dorsal scaphoid translation during push-up load, which I think is interesting. And some of the dynamic findings were not apparent in neutral imaging. And so this is an important indicator that perhaps dynamic CT is a helpful diagnostic adjunct.
Yeah, I think this is interesting. I've been spinning it around in my head now, trying to figure out how I would use this in practice, though. In terms of, they talk about using it fluoroscopically in surgery to check for reducibility of, the SL angle, which honestly, I usually will end up checking that with ulnar deviation. Maybe I'll try seeing it with axial loading to see if that makes a difference or bringing a wrist into extension. So maybe the next time I'm doing a dynamic assessment of SL, I'll include some of these just to see.
Yeah, I think I think about dynamic loading with the DRUJ a lot. And clearly, this is similar or even more important to understand. In my mind, this is like, as the authors say, it's an initial step in analyzing the in vivo carpal alignment under loads. And we're not doing that today. And how does that information guide us? Does it help us better understand outcomes? Does it help us better understand appropriate intervention like surgical technique? I don't know that I know the answer to those questions. And if any of our listeners do, share with us, because Chris will be happy to, record an additional podcast and discuss.
On SL, absolutely. Well, I think SL is still one of those black boxes, right? Like, we don't really understand SL. You see all these different techniques for reconstruction, and maybe this additional fundamental understanding will help us figure out different surgical techniques to address it. I think one thing is that, these are all patients, at least the ones who had the injury, they all had MRI confirmed complete SL tears. So, it wasn't just the volar component or, the membranous part, complete SL tears, but we don't know the status of the secondary stabilizers, which I think is an important thing to consider, because that certainly will affect some of these dynamic relationships, and that the authors acknowledge that. And then sometimes I think there was one patient who had to be pulled out because of pain during these activities. So clearly there's different spectrums of the injuries in the patients who are being assessed. And then perhaps they said there are a couple of people with bilateral SL injuries. So that may be an entirely different beast in terms of what their ligamentous status is in general.
I think it is a different beast, and I think that's really an important call out. I thought it was interesting, and it makes sense that basically the scaphoid reduces into the scaphoid facet of the distal radius when loaded in neutral posture. And so that's why the push-up bar is such an interesting way to test this. So it really gets you thinking, and it does likely have implications for how we think about repair, especially with the increasing interest in arthroscopic repair and the increasing acceptance that we still don't have good answers to this problem.
Yeah, it's nice because now I can tell patients that, do push-ups on a push-up bar because it's going to load your wrist in a more anatomic way.
I've been saying that for a while, but unfortunately, it doesn't. It's not a lot of people that go home and say, "Okay, I'll just live with it and do some push-up bar push-ups." Unfortunately for me,
That's why
yes.
I don't love this population either. So, all right, why don't we move to the best topic of the day, the nerve? Before we do that, we should mention our sponsors. So we've mentioned it before, but did you know the Checkpoint Guardian Nerve Stimulator is not just for, quote, nerve nerds? Guardian is frequently used in other orthopedic procedures like distal and midshaft humerus fractures, forearm fractures, elbow fractures, and revision elbow surgery for nerve identification and protection.
I just want to say thank you for leaving the last few words for me. Um, Maybe it's because I'm not a nerve nerd, but visit checkpointsurgical.com to learn more or reach out to the Checkpoint team. It is interesting. I do think that that's a true statement. While most of the Guardian and other stimulators are probably used by those that really focus on nerve, there is a role for these devices for all of us, I would just say selectively.
Yeah, I'd say, and then we've said this before, but if you're not a frequent user, just make sure that you have the grounding electrode appropriately placed, and that when you're trying to stimulate the nerve, you see the yellow blinking light, not red. Red means you're not applying the stimulus. Yellow means you are applying the stimulus. Because if you're making your decisions based on the nerve stimulator, you want to make sure that you're using it appropriately, and you can certainly talk to your checkpoint rep about that.
Absolutely. All right. Well, I hate to say it, but we're going to close this down talking about nerve.
So yeah, this was a great review article from Ken Porche at the Mayo Clinic, and his co-authors are the Mayo Plexus team: Robert Spinner, Alan Bishop, recently retired, congrats to him, Nick Pulos, and Alex Shin. So this is age-related effects on peripheral nerve regenerations, current concepts article that was recently in JHS, and just going through the reasons why outcomes may be, I guess, would say more variable and perhaps less consistent in patients with nerve injuries and attempted nerve reconstruction as patients age. So I will say kudos to them for managing to include the term over the hill in here at least once, which was nice to see. So nice job, Ken, on that. But I think that it's a review article, and it goes through the literature. There were some interesting kind of tidbits that I had not seen quantified before. So looking at they start by talking about kind of the biologic basis why nerve regeneration may not occur as reliably or as quickly in adults, and they say in here that regenerating rat sciatic sensory axons elongate at approximately 2.6 millimeters a day in young rats versus only 0.3 millimeters a day in aged rats. I thought that was just a really super fascinating thing to see, and you can kind of tell patients expect it to go a little slower because it's probably 9 times slower in aged rats. Now, they didn't say how aged the rats are. They don't say whether the
I
rats
know
just
what you're
had
thinking.
a
I'm
knee
the age
replacement
rat.
or it was funny. I still got asked the other day how old I was by a patient. So I was like, still got it. But
In a good way. When
in
they
a
were
good,
asking, "Are you old enough?"
oh, yeah, exactly. Yeah, exactly. And then I tell them how my daughter picks out my gray hairs. So it's okay. I'm all right. I'm going to cherish it while I have it. But they're talking about how the speed of regeneration is reduced partly because of increased axonal stiffness, in the cytoskeleton, and then also the Wallerian degeneration process, which is critical to kind of clearing the debris and setting the stage for regeneration. That's also slower because of the diminished inflammatory response as people age. And then the Schwann cells themselves, which are the critical part of kind of cleaning house and preparing, they also get senescent. So there are so many things, are kind of stacked against you as one ages in terms of nerve regeneration. The types of collagen changes in your extracellular matrix, the motor neurons don't, have as their axonal transport slows down, and then the muscles themselves that are denervated, they undergo more rapid degeneration and atrophy. So there's so many things here that would suggest that just nerves don't regenerate as well as patients get older.
And one take home point being, therefore, or this is another important consideration for nerve transfers, given how much they mitigate some of the age related processes.
Yeah, because with a nerve transfer, you're decreasing your distance to target, so you're getting there much quicker. But there's a question they raise here, which is really interesting about neuroplasticity. So can patients who are older have enough neuroplasticity to retrain the brain? Because now, for example, with the Oberlin transfer, which is a part of the FCU, excuse me, a part of the ulnar nerve, typically one for the FCU being transferred to the biceps, for example, you have to retrain the brain that it's no longer just wrist flexion, it's wrist flexion and elbow flexion. So that's pretty intuitive for children, and they've demonstrated that in one of the articles from Mariano Sokolovsky's group. But is that as intuitive for adults? Because we've seen patients come in And Lorna Khan, who's a hand therapist who's really pioneered a lot of the rehab work here, has a great slide where patient was never really taught how to activate their Oberlin, but then once they were finally told to do it, they thought it was a failed surgery. But then a year later, they were actually, when somebody finally told them how to do it, they were able to figure it out. But I think that plasticity and the importance of that re-education obviously has implications as folks get older.
Yeah, well said. All of that well said. Yeah, I mean, I think the take home is you're not too old in almost all circumstances for considerations, but think about timing, think about regeneration distance, and think about reasonable expectations. I had two social media things I thought about during this discussion, and you probably saw this because you're more social media in tune than I am. But one was when Alan Bishop retired, they did something really cool.
Yeah, that was
And
cool.
I always lament the fact that we at WashU, I don't think, do anything cool when someone retires. But basically, it was a walk of honor. And I've seen it before, but not that commonly, where after the surgeon's last case, he or she leaves the OR and staff and partners and all are lined up clapping. And that was really moving.
Yeah, that was really cool. And I saw a similar thing when Eduardo Salvati, a famous arthroplasty surgeon at HSS, retired, and they did a similar walk. And it's such a cool thing, and I think we definitely should do that for our celebrated surgeons. So yes, but I am also not as in tune on social anymore. I took the step, I deleted Instagram from my phone. I was killing too much time. So I will reinstall it. If I have to post something kind of work related, and then I'll delete it again. These are guardrails for my own sanity.
Yeah, I deleted TikTok. I haven't deleted Instagram because I sort of keep up with my kids, at least my daughters, and they post, and it's
Yeah,
just yeah. I try
I get
to
it.
avoid the rabbit hole. The other thing is many people who are listening know the name Jim Chang, who is a plastic surgeon at Stanford. I saw on social media that he recently flew his 1 millionth mile with United Airlines, and I'm thinking I don't know if
Wow.
that's a good thing or a bad thing. I think it might be a bad thing.
I hope a lot of those miles are for recreation. He has cool trips. I see him doing really fun stuff, and at least he takes his work trips and makes them fun. I know he brings along. I think for a while he was bringing along at least one of his kids on the work trips while they were still at home and everything. So hopefully he's making the most of it.
That's exactly right. That's exactly right. I'm not looking to meet or match his accomplishment in that domain though.
So I love how you found two ways to derail us from a nerve conversation, which is awesome. But I think, first off, figure one is a really cool figure. I think that, it's a good example for the younger folks out there that, picture is a thousand words, right? So a well done figure can convey the entire message, and it's right here. So it shows how you can still have functional recovery, but it's much more unpredictable as one ages. And I think the take home point from this is that recognizing, you talked about counseling and expectations. This is nice because it gives us pretty good numbers to talk to patients about in terms of what to expect. And also, on the flip side, it makes you, I don't like the word aggressive, but it may make you a little more apt to operate earlier for some of these patients because you know that, the odds are stacked against you if you're going to try and get some recovery. They're less likely to recover spontaneously because of the same processes. And if you're going to step in surgically, do it as soon as it declares itself, because that way you're going to set yourself up for optimizing your chances of success.
I think that's really well said. It is a wonderful figure. And, there has been talk of nerve compression recovery in a similar light. And it's not really the point of this article, but same idea. I mean, to me, if you're going to decompress a nerve, age has to be a consideration for expectations. And so that may be more applicable to many of our practices compared to, more advanced treatment of nerve injuries.
So shout out to the Mayo team for this great article. So hopefully if you're listening and you want to hear more of this kind of JHS journal club, let us know how we could tweak the format to make it more interesting for you guys as listeners. Handpodcast@gmail.com. And thanks again to Greg Merrill, Nash, and Macerena for the opportunity to present these articles.
Fantastic. It was super fun. I look forward to next time. So we're going to try to do these quarterly. Yeah, we're off to a good start.
All right, and if you want your article to get featured, make sure you're pushing Nash to pick your article.
Yeah, don't reach out to Chris and I. This is not, we don't pick the articles. We just talk about them.
All right, have a
All
great
right.
day.
You too. Thank you.